Good evening, everyone, and thank you for joining our virtual community lecture brought to you by Providence St. John's Health Center and Providence Little Company of Mary Medical Centers. Our focus this evening is on the very broad topic of brain health, and I'm Dr. Daniel Kelly, Director and co-founder of the Pacific Neuroscience Institute. I'm very happy to be joined by two speakers tonight, psychiatrist Dr. David Merrill and neurosurgeon Dr. Wallavan Sivakumar, two of my favorite and most accomplished physicians at Pacific Neuroscience Institute. Before we get started, I want to let everyone know that this is an hour-long presentation that is being recorded, and we'll have plenty of time for questions at the end. You can also use the Q&A box to type in questions, and we'll do our best to answer all of them at the end of the presentations. And please note that we're not able to answer personal medical questions, but certainly can talk in generalities. And if we're unable to answer your question, you can email us at lalectures@providence.org, and we'll try to get back to you at our earliest convenience. Providence St. John's and Providence Little Company of Mary, in collaboration with Pacific Neuroscience Institute, provide top-tier advanced treatment for the full spectrum of brain health and neurological disorders. We have a very large multidisciplinary team. We offer comprehensive management from brain tumors to stroke to Parkinson's disease, facial pain, hearing loss, visual decline, and even more. We have an extensive range of brain health treatments and leading-edge minimally invasive treatments, some of which you're going to hear about tonight. And lastly, we want you all to know that the information provided for this program is really for educational purposes, and you should always consult your care provider if you have specific questions about your medical condition. And so right now, it is my pleasure to introduce Dr. David Merrill, who's going to provide insights into comprehensive and holistic approaches to the broad topic of brain health. Dr. Merrill is a board-certified adult and geriatric psychiatrist with a clinical focus on the prevention and treatment of cognitive decline. He's a recognized expert in the field of brain health and Alzheimer's disease prevention, and with a unique approach that integrates personalized medical, lifestyle, and dietary interventions aimed at optimizing brain function, which you're going to hear about tonight. He currently serves as our director of the Brain Health Center at PNI in Santa Monica at Providence St. John's, where he combines leading-edge science with holistic care to support cognitive vitality. He's a very busy man. He's an avid fitness enthusiast. He makes time for regular exercise. He practices what he preaches. And Dr. Merrill also enjoys baseball. He's a spectator and a participant, finding a perfect way to combine his love for the outdoors and fitness. And with that, Dr. David Merrill. Dave, take it away.
Thank you, Dr. Kelly, for that kind introduction, and thank you, everyone, for joining us this afternoon or whenever it is. So I'm going to give the first half of the talk about navigating brain health in the modern-day health system and beyond in our world, and talk about the need for comprehensive care of the brain and body to achieve optimal longevity. A little bit of timely news. Today is October 3rd. Just a couple days ago, Jimmy Carter was the first and only president to have celebrated his 100th birthday. So that is quite an achievement, which was celebrated by his hometown in Georgia. He wasn't physically well enough to attend the birthday party, but he sent his well wishes and he let everybody know that he's looking forward to voting in the upcoming presidential election. So Jimmy is a great example of somebody who has achieved an element of optimal longevity, given that at age 100, he's talking to us about participating in a really important process, which is casting a vote in the upcoming election. So this demonstrates something very important for us to be thinking about as we enter into today's session. What is it? What's the point of living a long life? Is it really about the lifespan that we're going to have versus something that we like to call the health span? In today's modern world, we tend to have normal aging in which the last decade or more of life is spent managing with the debility caused by age-related diseases, cancer, heart disease, diabetes, and yes, memory loss, which we're going to go into in detail here in a moment. My goal as a provider and really as a person is to help myself and others, loved ones, patients, and the community to achieve optimal longevity by expanding the health span as late as possible into our lifespans, maintaining the reality that we're all going to die. In any case, if you'd like to see a popular book about this that's just come out by Dr. Peter Attia, he talks about people competing in the Centenarian Olympics. And if you'd like to be making it into the Centenarian Olympics, you have a less than 1% chance of making it to 100. And if you want to be in the games, you have to use it or lose it. The last thing that any of us really want to do is be a burden. We don't want to live into stages of severe debility and dementia in the case of cognitive function. So how do we keep ourselves in the blue zone as opposed to transitioning into the red zone? With memory, with aging, it's an example of how with aging, one can end up in the red zone into a mild to moderate or severe state of dementia where you no longer know that there's going to be an election. You no longer know that it's time to vote. So how do we stay preclinical? How do we stay healthy in an optimal brain state? Well, there's books about it coming out now, 2024. We're doing webinars. Some of us have been studying this a little longer. I wrote my first article about this in 2011. And so I'm glad that it's caught on and it's remained important to society at large. And why is it so important? Well, neurodegenerative disorders are exploding onto the scene. Right now, Alzheimer's disease, there's 55 million cases globally. By 2050, it's estimated that there'll be nearly 140 million cases. And it's not just Alzheimer's. Parkinson's, ALS, Huntington's, MS, all expected to increase in the coming decades, both to the aging of populations, and also we're getting better at identifying that these cases are happening. Now, as the quote says here, these numbers may vary based on advances in treatment and, importantly, prevention strategies. Indeed, there's an urgent need to improve the standard of care for Alzheimer's and other age-associated neurodegenerative diseases. We know the natural history of these conditions, and it's not pretty. Standard care, prescriptive, Western allopathic medicine-based memory clinics for Alzheimer's, which this is an example of a case, results in approximately 8 to 10% per year decline in cognitive functions and a 3 to 5% per year total volume loss of the brain. So here was a case at a leading quaternary academic medical center in the Western Hemisphere that was cared for between 2009 to 2015 at a state-of-the-art prescriptive memory clinic. And you can see by tracking the volumes of the memory centers in the brain, the natural history of the disease, if we do nothing other than track and prescribe, is to decline, decline, decline. Why is that? Well, Alzheimer's disease and related dementias are the most common dementing brain illness associated with aging in the world. A number of cases are associated with genetic risks, including the most commonly known genetic risk, which is the apolipoprotein E gene variant number 4. So we each inherit one copy of a gene from each parent. The ApoE4 variant gives you a higher risk for Alzheimer's disease with aging than you would otherwise have with the so-called wild type or normal genotype, which is the ApoE3 variant, or a very few lucky individuals have an ApoE2 variant, which is the rarest form of the ApoE genotype. This is a non-modifiable risk. It's the most common, widely known, non-modifiable genetic risk for later life Alzheimer's. The number one non-modifiable risk is age. Every year over the age of 60, your risk for developing Alzheimer's increases, and it remains present no matter what you're doing day to day in your lifestyle and with your health. So for these non-modifiable risk factors that you're born with, what can we do? Well, ApoE is certainly a potential target for precision medicine interventions. And what does that mean? So your genotype may influence the response to a risk reduction strategy, for example, diet or exercise. How is this working in the brain and the body? We know that ApoE4 version of this protein contributes to Alzheimer's disease formation and progression through disease-associated microglia activation, or DAM brain aging. It also happens through disease-associated astrocyte activation and brain inflammation. We also see that with ApoE4 genotypes, there's greater brain-blood barrier breakdown, or BBB breakdown. And ultimately, ApoE4 contributes to a state of insulin resistance, which is why Alzheimer's is sometimes known as type 3 diabetes. But in fact, knowing your ApoE4 genotype nowadays can actually be helpful, because we can prescribe a diet for the ApoE4 genotype that benefits the brain with aging. What does a prescription diet for ApoE4 look like? One that's heavy in extra virgin olive oil with healthy polyphenols. Doesn't have to be breaking the bank. You can go to Trader Joe's and get premium Italian EVOO at 1 to 2 tablespoons 2 to 4 times a day. You also want to have generous amounts of cruciferous vegetables, fatty fishes that are low in mercury, the so-called smash fishes, the most popular which is salmon. And we really want to limit alcohol. As far as the macros of your diet, carbs, fats, proteins, we see that lower carbohydrate diets are associated with thicker brains. And the ketogenic diet, which is the lowest carb diet possible, actually, in some studies, we found symptomatic improvements in Alzheimer's. In our own Providence affiliated P&I research group, we found and described in detail at national and international conferences and now in publications that indeed the lower carbohydrate diet is associated with greater brain thickness, particularly in the frontal lobes. Very important part of the brain for decision making and processing and living life to its fullest. This is work I'm not doing in isolation. There's really no such thing as individual research study. Is now team science. I'm helped by the likes of Dr. Brayman, Masami, Emily Popa, Dr. Siddharth, and we're really putting it out there in places like the Journal of Alzheimer's Disease. This study led by Dr. Masami showed that muscular grip strength and physical mobility were also linking to brain health. This was published in the Journal of Alzheimer's Disease way back in 2022. We're not the only group doing this. Independently, Dr. Heather Sanderson, who's a naturopath down in Encinitas, California, at her Solcere clinic, produced and performed an independent replication of the Bredesen protocol approach, showing improvement in cognition with a personalized precision medicine plus lifestyle intervention in her clinic patients. The patients had clinic visits 4 times over 6 months. They had weekly calls from health coaches, and they were encouraged and given instructions and essentially hand-holding coaching of how to make healthy brain changes in their lifestyles, including more movement, working towards the ketogenic diet, reducing the stress, taking key supplements like omega-3 fatty acids, and using medications judiciously in a way to support global health and brain health in particular. Over the 6 months of the study, it's astounding that they saw improvement, shown here by the bar graphs, in cognitive scores over the course of the 6 months. This is not supposed to happen. We saw on the prior slide the natural history is decline, decline, decline. And here, she and others have been showing that you can actually get stabilization and or even improvement with treatment of Alzheimer's or those at risk for Alzheimer's with this precision medicine personalized approach plus lifestyle intervention. So at Providence, St. John's, P&I, we actually have a precision brain health program where we're working towards providing clinical health optimization and experiential lifestyle services to develop, deliver, and then research and disseminate a new set of best practices for Alzheimer's prevention and care. We don't just give handouts, we don't give pamphlets, we do give lectures and webinars, but that's really to encourage you as a call to action to get experience in life living these interventions through hiring a health coach or seeing a nutritionist or doing some brain training classes. What is brain training for us? We have something called Fit Brain Dual Tasking Program, which combines cognitive training and exercise at the same time. So these are customized to the individual by persons like Ryan Glatt, our Fit Brain director, and other members of the team. These can be done as an individual or in group, virtually or in person. And it's not just about you coming to our center or getting services from us. There's more and more of these resources available on the internet through web-based programs, either recorded or live. And we're more than happy when people decide to do this on their own, wherever you may be located. It's part of one of the silver linings of the pandemic is that these things have become more and more available in the community and across the globe over the computer. The rest of our lifestyle team, led by Dr. Miller, includes nutritionists and psychologists and care coordinators. And we're just here to help people have the best possible experience with improving the health of their brain. Here's a case example from our center. Over the course of a year, the parietal lobe blood flow increased by 52% compared from the beginning of their treatment intervention to after the point of a year. And the increased blood flow is shown by the increase in the red color where I'm circling my arrow, and it's basically the targeted area. The parietal lobe is one of the regions of the brain that tends to shrink over time. And this is in a patient with confirmed Alzheimer's disease pathology, which I'll talk about in a minute, how if you're interested, you may want to find out for yourself whether or not you have the beginnings of the Alzheimer's disease process. So here again, the blood flow improved, and we actually saw growth of the brain over the course of a year. We've been hard at work trying to replicate this in other patients, so it's not simply a one-off or a case example. We had a group of patients that we tested before and after a 6-month intervention, measured their cognitive performances. The post-testing is all of the orange bars. And you can see in several areas, including spatial planning, visual spatial processing, and global cognition, there was improvement over 6 months in these adults with mild memory loss. Here's just a cover of a recent journal article showing one of our clinic patients where the red arrows are showing growth of the hippocampal memory center over 1 year of lifestyle intervention plus precision medicine. Now, I'm proud to say that at P&I, our goal is to provide this sort of care for all neuroscience service lines. We have a Dr. Barbara Geiser, who's our director of MS clinical services. She worked with our health coach and exercise team to deliver a lifestyle intervention to those with early MS and found that the intervention improved both cognition and quality of life. This is just hot off the press. It actually doesn't come out until November 2024, which for those of you who are oriented is next month. So, is this something that's really catching on that people are doing? Absolutely. There's now what's called a Lancet Commission that's looking at modifiable risk factors for Alzheimer's. In 2017, they had identified 9 factors attributing for about 35% of cases. Now we're up to 14 factors, which are accounting for upwards of half of all cases of dementia. The factors with the largest attributable risk include hearing loss. So in the Neurosciences Institute, we want to have things like a cochlear implant program. We want to have hearing assessments and restoration. High LDL cholesterol, new for 2024. 7% of dementia cases are attributable to LDL cholesterol being out of control. So we see that what is good for heart health, because you can lower the risk of heart attacks from controlling your cholesterol, is also good for brain health. Another factor that comes up late life is social isolation, especially amplified by the COVID pandemic. I think y'all are doing a great job by joining and watching this YouTube video and webinar to educate yourself. A modifiable risk is how educated are you? It's to build up cognitive reserve. In early life, if you missed out on rich education opportunities, here we are. It's the democratization of education. Back in 2011, my review had 72 references on brain health. Now the Lancet Commission has almost 600 references, so the evidence base for this is large, dense, and extensive. There was a doctor who said if healthy lifestyle were a drug, we'd prescribe it to all the patients. Lifelong pursuit of education is neuroprotective. In midlife, there's upwards of 10 modifiable factors that can be addressed. And the good news is that when you address one factor, it also tends to improve others. For example, treatments of obesity tend to improve metabolic syndrome like diabetes, also improve vascular health and heart health like we talked about for LDL cholesterol and also blood pressure and etc. It's also true that exercise has been found to be as effective for mild to moderate depression as antidepressants, and you get an even better effect when you do both. The more factors that are addressed, the lower your odds of developing or worsening your memory loss over time become. And this is being pronounced far and wide. Providence P&I research is now cited in the 2024 Lancet Commission update that exercise can boost brain health. We did an analysis from patients across both America and Canada in collaboration with our academic partners and community partners and found that MRI brain scans of those exercising moderately for only 25 minutes or more a week had bigger brains in multiple regions. So you don't have to be a marathon runner. You don't have to be a triathlete. Really, if you just start moving, it's never too late to improve on your brain health. One of the most recently added factors, vision correction, is a focus of our group at P&I. We have a great new vision rehab team led by P&I founder, Dr. Howard Kraus, and his collaborators and colleagues in neurooptometry and occupational rehab. So both here and afar, they were just at an annual conference talking about integrating vision into brain health, brain-based therapies to show that the whole goal here is to keep people in a pre-pathology state. Now, you may want to take a screenshot of this slide. I had to look at it several times over several days to understand it. The upshot is dementia does not happen overnight. Dementia is functionally disabling syndrome that occurs 20 to 25 years after the pathology starts. You can now get a blood test to see whether or not you have the disease processing starting, even when you're not symptomatic. What does that do? That's a motivator. You can try to help stave off going into the pathological state of the illness by trying to modify these 14 modifiable factors we've found. If you have an at-risk genotype, prescribe yourself an anti-ApoE4 diet. The whole goal is to get you to optimal longevity. So instead of going into the purple state or the red state, you stay where it's safe. You stay in the blue state. And I'm talking about health. So in any case, thank you for your time. And that concludes my portion of the presentation.
Dr. Merrill, that was excellent. Thank you so much for a really stimulating talk. You covered a huge amount of territory, and hopefully, I'm sure there's a lot of questions for you at the end. But we're going to move on now to Dr. Sivakumar. And so we're going from brain health to brain tumors. And I think this is really demonstrating sort of the breadth and depth of what we have at Pacific Neuroscience Institute. And really, brain tumors is where we got our start at P&I. And we've had a number of wonderful fellows over the years. And Dr. Sivakumar was one of our fellows, and he really now leads the brain tumor program down at Little Company of Mary. He's obviously a board-certified neurosurgeon. I think he did 3 operations today. He's got a focus on skull-based tumors and minimally invasive treatment of brain tumors. He's a multiple Super Doctor Award recipient. He has over 40 peer-reviewed publications, and he's got a lot of broad interest beyond brain tumors in neurosurgery. And his focus, like all of our neurosurgeons at P&I, is to minimize collateral damage to the brain and do what we call keyhole surgery. And he's going to talk quite a bit about that today. He also does spine surgery. And he's available also for things beyond brain tumors, including things such as vascular malformations, cerebral aneurysms, and carotid stenosis. He is a super busy guy. We're very happy he could join us today. In his free time, which he doesn't have much of, he enjoys tennis, yoga, and spending time with his beautiful family. So, Dr. Sivakumar, please take it away.
Thank you, Dr. Kelly, for that very kind introduction there. I really appreciate the chance to speak with you all. I take a lot of pleasure out of these talks and being able to communicate with our with not just specific direct patients, but talking about this situation when you have a time where you're not immediately impacted by this problem. I'll tell you, when patients come in and they learn about this brain tumor in clinic for the first time, it's a formative experience for one, but it's definitely something where it's hard for patients to really concentrate and take everything in just because of the stress of it all. So events like this are very useful to try to get your head around a really complicated topic. Because it's complicated, it requires really a village of a team to manage it. And these are some of my colleagues that I take inspiration from and work from to put these slides together. No real relevant disclosures for this
Ollie,
topic.
we're not seeing your slides.
Oh, I'm sorry. Let's try this one more time. I'm hoping it's up now.
There you go. You're good.
There we go. I can't see the Q&A box, but hopefully Dr. Merrill can take it from here. So here are some of our colleagues and no relevant disclosures. What we're going to focus on today are looking at primary and secondary brain tumors and the difference in between them. Some of the common ones that we see, some very basic brain anatomy to get a sense of how some symptoms localize. Management strategies, specifically the focus on keyhole brain surgery, as Dr. Kelly alluded to, and my primary research focus at the current time, which is enhanced recovery after surgery. So what do I mean by primary versus secondary brain tumors? Primary brain tumors are those that originate from the nerves that make up the brain or the support cells that are involved with the nervous system. When you break them down, the WHO currently, as of the last update, have 126 different types of primary brain tumors. When we're talking about secondary in this context, it typically refers to metastatic tumors or those that come from other places inside the brain. Interestingly, the metastatic tumors are much more common than primary brain tumors. And the most common ones that actually go to the brain are breast, lung, kidney, gastrointestinal tumors, and melanoma. Common one that the St. John's Cancer Institute has made significant contributions to over the years. Interestingly, the number of metastatic brain tumors are growing in the recent decade, likely related to the improvement in terms of the medical management, including chemotherapies and immunotherapies that allow patients to live longer with cancer, which increases your risk of developing metastases coming up to the brain. But I think Dr. Kelly can attest to our overall surgical volume of the tumors that need operations by a neurosurgeon have actually gone down anecdotally. And I anticipate in the next update of the WHO, we're going to see that. Now, of the primary brain tumors, the most common ones include meningiomas, which are the most common primary brain tumors, gliomas, and these include a spectrum of diseases ranging from benign gliomas all the way up to malignant or glioblastoma, as it's commonly referred to. My favorite tumors, and the reason that I was able to link up with Dr. Kelly, pituitary adenomas, are the third most common, and schwannomas as they occur in multiple different parts of the brain. As you can see here, as I mentioned, metastatic brain tumors outnumber primary brain tumors by quite a margin, a factor of at least 3, potentially growing. The etiology of the tumors, we typically say unknown. There are likely a combination of both environmental and genetic factors, and my hope is at some point here we're going to be able to pinpoint exactly what those are. Over the last several decades, many of these risk factors have been suggested and studied, but nothing has come out conclusively as a cause outside of very extensive radiation, typically in childhood, as was common several decades ago to get very aggressive radiation in a lot of childhood cancers, which led to the increase in tumors. Outside of that, things that have been suggested or popular, things like head trauma, petroleum, aspartame, and the one that is in society significantly interesting to discuss, which is cell phones. And there have been several different studies that have looked at this, but no strong recommendations or connections to cell phones at the current time have been released to really make any change or any convincing change to the practices. Now, a common question that comes up in clinic is what size do these tumors have to be, especially in a large number of these tumors that Dr. Kelly and I see. We probably actually see more patients with brain tumors than we actually operate on, and by quite a number. What that means is that these tumors are present, but they're not causing symptoms or enough deficit to warrant surgery. And that is very variable because the symptoms are more dependent on the location of the tumor more than the size itself. As you guys know, the brain is not a homogeneous structure, so there can be a lot of variability where a large tumor in one place of the brain could be sitting there idly versus a small tumor in another area that could be wreaking havoc on patients. And my hope is you don't know many people like that, but the odds are you've come across that or you've been touched by this issue in some way, shape, or form. And then when we're talking about normal brain anatomy here, a couple of different things. The frontal lobe is a cognitive center in the brain, even though, as we know, and now more modern neuroscience is showing, there's so many more connections between the brain than originally thought. And we're still very much in our infancy of understanding the true extent to how far that goes. But to think about it, to simplify it, the frontal lobe is associated with cognitive functions and voluntary movement. The parietal lobe back here is involved in processing a lot of the sensory input that comes into our brain, what we see, hear, and other things. The occipital lobe is focused on the visual information. The temporal lobe is noted to be involved in memory and hearing. And the brainstem deals with many of the unconscious functions that keep us awake and alive, like wakefulness and breathing. Now, because the symptom presentation varies, the brain tumor care is heavily reliant on multidisciplinary input. And it's great that I was able to follow Dr. Merrill, who put this in a very beautiful way in terms of how brain health is treated. And it's a core philosophy of everything we do at the Pacific Neuroscience Institute. It really, really takes a village when we evaluate and treat brain tumors. The diagnosis at the current time, and this is in the process of changing actually, is only made by pathologic evaluation, but there are impressive potential things coming out in the pipeline, like blood work and something called liquid biopsy that potentially can get us answers and get the treatment process started earlier than we currently have. Unfortunately, when you're looking at this pathology, the interpretation is still quite variable. It's not an absolute. If you give pathologic specimens to 10 very well-trained pathologists, it is possible to get multiple different diagnoses. A couple of reasons for that. Tumors tend to be mixed, where you have areas of high-grade components and low-grade components, and the real classification of these studies are constantly in flux. The WHO, which is the World Health Organization, has an iterative log of the classifications of tumors. And every update that they do, there's always several specific changes that have occurred to the the identification and diagnoses of brain tumors. I really always like putting the slide in any talks that we give, not just in PNI, but Providence as a whole. The reason I think that our partnership with Providence is so successful is because they are committed to this concept as well, where anything and everything will be done to get our patients all of the specialty care at the highest level that they're going to need. And these are some of the different physicians and other caregivers that are involved that could touch a patient's life. And not just the patient, but you'll notice here the support system, which is often an overlooked area, and I appreciate the attention that the Pacific Neuroscience Institute and Providence gives into ensuring that families and friends have everything needed to help patients along this formative journey. Now, the role of surgery is something that's in flux, and it's changed quite a bit, even in the young 15 years that I've been doing this. Initially, brain surgery used to be the end-all be-all, but it's moved into a situation that's a lot more nuanced. We still require surgery in the majority of brain tumors, and when we're doing surgery, we're really trying to hit this balance between maximal safe resection, but doing it in a way that avoids adding new neurologic deterioration. What's happening is that we've had this development and Pacific Neuroscience Institute has been involved in the development of several different adjuncts that have been used to help us, quite frankly, remove more tumor. These are a couple of the big studies shown in glioblastoma that showed that the more tumor that's removed, the better the survival is, plain and simple. And for the majority of tumors, this is how we practice. That being said, the second that a new neurologic deficit is introduced from surgery, not only do you lose that initial benefit on survival that you get, but typically it decreases past the point of, potentially not doing anything at all. So that's a very important point to consider, and something we take very seriously at PNI. Now, brain metastases, for example, historically, things went from hope and prayer, meaning there's nothing to be done and to go ahead and get your affairs in order. And then it went to surgery being the only treatment offered. Only, as far now it's 25 years. Patchell came out with his landmark study showing that the combination of surgery and whole brain radiation for single solitary metastases were superior to other treatment modalities. As things have grown and the technological adjuncts within surgery, the surgical expertise, the introduction of minimally invasive surgery that I'm going to go into shortly, and the development and improvements on the radiosurgery platforms have extended in conjunction with targeted therapies and immunotherapies to give a really multimodal treatment for metastatic brain tumors. So how do we make these treatments safer and more effective? One of the core principles of brain tumor surgery at the Pacific Neuroscience Institute, and I see several of my patients in the audience, and we've actually talked about some of this, is when we're talking about surgery for brain tumors, it's only the beginning of treatment. We're aiming for this maximal safe resection, typically to, essentially prevent dysfunction from worsening, but hopefully restoring function and your quality of life without introducing new neurologic deficits. We want to be able to get these tissues to get the proper studies done to optimize the specific type of chemo or immunotherapy or radiation therapy. And we want to use a surgical approach that promotes early mobilization and a short hospital stay. So that's where this concept comes in. This keyhole or keyhole brain surgery is loosely means accessing the brain via smaller, more precise openings to minimize brain, scalp, and muscle manipulation. And something that Dr. Kelly has been one of the the early introducers into the neurosurgical world and one of the luminaries in the field of endoscopic skull-base surgery, where you can advance those skills and results even further. As I mentioned, there's less bone soft tissue disruption, so there's less retraction on the brain as well. And what that ends up doing is preserving more of the normal physiology of the brain. When that happens, there's less collateral damage, and then there's a more rapid recovery and a shorter hospital stay. But the shorter hospital stay gets you to the next step of your treatment faster. We do that through a variety of different methods. And at the P&I, where in terms of these minimally invasive approaches, several of our surgeries are done through the nose via using these high definition cameras called the endoscope, often or always in conjunction actually with our ear, nose, and throat surgeons who we referenced earlier. The supraorbital eyebrow craniotomy that has a very interesting cosmetic profile, but also a more direct access to the frontal part of the brain all the way back to the brain stem. And then other things like gravity-assisted approaches that we can talk about in the Q&A if there's interest. To do this, though, it requires a tremendous technological investment. And we are blessed at the Pacific Neuroscience Institute, in conjunction with Providence, to have the support from our partners to really not ask or need for any type of technological adjunct. Anything that's out there that's been proven to improve surgical outcomes, which ultimately results in the improved quality of life for patients, we have been able to get, and to the betterment of the health of our patients. One of these, for example, when doing biopsies and using these keyhole approaches, visualization is usually minimized. And this is just one example of these fluorescent painting dyes that really can show a clear demarcation between the tumor and the normal brain itself to help with maximal safe surgery. As I mentioned, I love this slide of Dr. Kelly's and present it whenever we can. I'd like you guys to take a look at all of these patients here and try to guess which side each one of them had surgery on for a brain tumor specifically. And you'll see it's pretty difficult in the vast majority of these patients, because through these minimally invasive approaches, you can't really tell where they've had surgery. And that's psychologically what I've found, even increasing as the years go on, incredibly important to these patients with brain tumors, particularly malignant brain tumors, as they need to go on to several other treatments. This isn't just the end of their journey, and it typically requires an upheaval and a stop to their life. And everything we do that can help them feel as normal as possible, as fast as possible, goes a long way in maintaining both their mental health and their psychological state going into these usually aggressive treatments. Another part of that I'm very, very interested in is this concept of enhanced recovery after surgery. Okay, you can do a wonderful surgery, but if a patient gets stuck in the hospital for several days and run into the problems associated with being in a prolonged hospitalization, it can undo a lot of the positive impact from the surgery. So this concept, P&I are pioneers in bringing it into brain surgery, is enhanced recovery after surgery. It was actually introduced now more than 25 years ago in Western Europe for abdominal surgery. And it looks at taking multimodal approaches, all focused using every healthcare provider who touches a patient during their hospital journey, and all focused on reducing the stress response related to both surgery and the hospitalization. And when I say it involves everyone, it involves every single person that you'll see in the hospital through your journey. All of the protocols are based on best published evidence, and we've seen tremendous improvements in several different very important metrics. Other things that have shown across other surgical specialties is that minimally invasive surgery is a key component to enhance recovery success, and it's implemented across several other surgical instances. And I really believe this represents a paradigm shift in the surgical treatment of all patients. At the P&I, about 6 years ago, we developed our own neurosurgery enhanced recovery protocol for all cranial surgery. And this has actually served as a model where across the rest of the world, neurosurgery was kind of one of the late adopters to enhanced recovery protocols. Here at Providence, neurosurgery's enhanced recovery protocol is serving as the template and the baseline for adopting widespread ERAS protocols across all the surgical specialties, across all of our 52 hospitals for Providence across the Western United States. And as I mentioned, P&I are leaders in this enhanced recovery after cranial surgery. This is a paper that we published in the end of last year in a specific neurosurgical issue directly focused on enhanced recovery efforts. I want to move on to questions. So in brief, brain tumors represent a very complex pathology that we're only scratching the surface of during these 18 minutes. Surgery now represents only a part of the management of brain tumors. We believe keyhole brain surgery is a safe and effective alternative to traditional cranial approaches, and these technological adjuncts that were addressed have resulted in improved clinical outcomes in patients undergoing brain surgery for tumor. And enhanced recovery after surgery, we believe represents a paradigm shift in the optimization of care for all surgical patients. And most importantly, as was discussed for all P&I related things, it's truly a comprehensive team effort. It takes a village, and it requires everybody centered around the patient, including their support system that I'd love to talk about more here during the Q&A. So with that, thank you all for your attention. Here are some of the handles that patients have requested here to see more information about what Providence and P&I is up to. Thank you very much.
Great. Thank you, Wally. That was fantastic. I think, as you all can see, it's a very complex world that we live in, and challenging problems that we take care of both at the far end of the spectrum related to brain health and dementia and with brain tumors. And it really does require a multidisciplinary team effort. Before we get on to questions, I would ask you all, those of you attending, to please answer the poll that you see on your screen. If you can, just to give us a little feedback on what we've presented, that would be very, very helpful for us. So I guess now I'm going to ask Dr. Merrill and Dr. Sivakumar some questions, and we'll see what other questions come in. My first question for Dr. Merrill, you mentioned the importance of hearing and vision, and these are being increasingly recognized as problems that can contribute to cognitive decline and memory loss and isolation. Interestingly, as Dr. Sivakumar mentioned, a lot of what we treat in the realm of brain tumors affect hearing and vision. And one of the newer programs we now have at Pacific Neuroscience Institute is a cochlear implant program led by our otologist, Dr. Courtney Volker, and it's really a wonderful program. And Dave, I just wanted you to maybe comment on the benefits and what you've seen in patients when they do have, say, hearing restoration from a cochlear implant, which, by the way, is another minimally invasive procedure that can really bring the world back, bring the ability to communicate back for an individual with their loved one. So Dave, do you want to comment on that?
Absolutely. Thank you, Dr. Kelly. So just earlier this week, in fact, I was sitting in my office across from a patient who had just received a unilateral implant from a cochlear implant from Dr. Volker the month before. And he looked at me and he said, Dr. Merrill, this is the first time I've been able to sit with you and hear you together, like one-on-one. And so it's a remarkable thing to work in an institute where my co-faculty members are collaborators and partners, and we're just synergizing together. So now he's actually starting in the Fit Brain program to rehabilitate his cognitive function, and the future looks bright for him and others.
Thanks, Dave. Yeah, I would say, again, one of the things we're pointing out here between brain health and brain tumors, there's a lot of sort of cross-pollination and cross-referrals from our different centers of excellence, so that some of our patients with brain tumors obviously develop cognitive and memory issues, in part sometimes related to our treatments. And so there's a lot of patients that will end up going to the Brain Health Center for optimization of their function and to try to relearn things. And I think that's a really important point. So I see some questions coming in. Dave, I think this is for you. Very good question. Do cognitive exercises make a difference, or is only learning and forming new connections proven to help?
Oh, thank you for the question. So cognitive exercises do have good evidence for helping support and preserve memory function with aging. That's in large randomized clinical trials. There are limits, of course. It's not the only factor. And something that we found to help boost the effect of cognitive exercises is to combine it with physical exercise at the same time. When you get into the zone, so to speak, with moderate intensity aerobic exercise, your muscles send signals to the brain called myokines, or muscle signals, including brain-derived neurotrophic factor, which are neuroplasticity factors, and cell survival factors that really tell your brain to stay alive. And if you're testing the brain and trying to learn something new, you are forming new connections with new learning. And the physical exercise process can help boost the impact of the cognitive exercise process. It's called dual task training, and it's a wonderful thing. So cognitive exercises absolutely make a difference. It's use it or lose it for your muscles, your bones, and your brain.
Yes. Thanks, Dr. Merrill. Someone is asking, what is the best way to communicate with someone who has dementia? And I guess that would depend on potentially how advanced their dementia is, whether it's mild, moderate, or severe. What are your thoughts on that, Dave?
Yeah, so Celia, it's a very important question, and I don't want to make light of it, but the best way to talk to someone with dementia is like the way that you would talk to someone, lovingly, supportingly, with curiosity and understanding, trying to meet them where they're at. I have a lot of fun in my job. I see persons living with all stages of dementia, whether it's mild, early onset, moderate, late stage. And I find that bringing joy, you can really find moments of joy with people, no matter what level of impairment they're at, where it's just really a matter of meeting somebody where they're at, letting go of your own expectations and trying to assume the care partner role, where it's like, what's going on? Like trying to really be curious about how they're perceiving something. As you can tell, I could talk all night about this, but thank you. That's a great question, and something that really takes a lifetime to work on and improve on. So thank you.
And very, very challenging. Dr. Sivakumar, I wanted to just ask you a question. In terms of what do you think is going to be the next big thing in brain tumors? I am kind of putting you on the spot. And maybe before you answer that, how quickly can you get a brain tumor patient in and out of the hospital today? I mean, how long are they in that? What would you say our average length of stay is now?
Yeah, it's a great question. We take that point very seriously for several different reasons. The reason for getting somebody out of the hospital is not just to get the number, but what it's shown is that it reduces the risk of secondary complications that often get in the way. Things like urinary tract infections, deep vein thromboses, pulmonary embolisms. These things can really get in the way and cause a lot of problems after surgery. But the next part of it is what we're doing currently at the Pacific Neuroscience Institute. The majority of patients undergoing brain tumor surgery, either transcranial or endonasal, are going home the day after surgery, sometimes the same day of surgery. and getting back to normal activity without activity restrictions within about 2 to 2.5 weeks after surgery. And how that's relevant here on the malignant tumor side is that we can really decrease the downtime between surgery and starting either chemotherapy or radiation therapy or immunotherapy.
That's great.
I learned
Thanks,
that from
Wally.
you.
The next big thing, I think to be determined
Yeah,
what the next big
yeah.
thing is. We're working on it. I want to get to I think maybe one more question, maybe two, on Parkinson's disease. Can we apply the same preventative strategies as you talked today? Oh, that question just disappeared.
Dr. Kelly, I typed an answer
You got
for the
it, Dave.
lifestyle part, so maybe either you and/or Wally could speak to the second half of the question asked about can you use minimally invasive brain surgery techniques for Parkinson's?
Wally, you want to talk about that?
Yeah, so that was specifically for Parkinson's disease. That's a great question, and it's a wonderful segue. I was trying to figure out a way to get that into this talk. The Pacific Neuroscience Institute, through incredibly generous philanthropy support, were we are in the process of installing our focused ultrasound machine. So this is a way to treat movement disorders, specifically essential tremors and tremor predominant Parkinson's disease, with what's called incisionless surgery, where it allows you through a very high-tech ultrasound machine in collaboration inside the MRI scanner to create a lesion in the part of the brain that both the neurologist and the functional neurosurgeon determine to show dramatic improvements in the course of these problems. We're incredibly excited about it. The construction has just started and is slated to be completed and ready to go for patients at Providence St. John's Hospital and Little Company of Mary in June of 2025. So we're so excited about that.
Great. Thank you, Wally. Unfortunately, we're at time here, and we're not going to be able to answer all the questions. We'll try to get to that, though, in the chat here. But I really want to thank Drs. Merrill and Sivakumar for talking with us today, for the Providence team for putting this together. As the map shows here, Providence has you covered for your health needs, particularly for the neurosciences, which is what we're talking about tonight. And we thank everyone again for their participation and for your engagement. And we look forward to caring for you and your family. Have a great evening.
Bye, everyone.
Thanks, everyone.